And so, I think this conflict among guidelines has been very apparent to many of us uh, in oncology and other fields of medicine as well. And I became very interested in this topic because I have an interest in screening, and there are enormous differences in breast cancer screening guidelines around the world. And I was always puzzled as to why people could look at the same data, doctors could look at the same data and arrive at very different conclusions. And so Sunita and I had some ideas about this, and we put together this editorial. And I'm going to summarize some of the comments of this editorial here. Now, I think the other important thing to understand is that that there are different health systems here at play. The United States is a fee-for-service healthcare system. In other words, doctors make their income depending on what procedures they do, what surgeries they do, and the more they do, the more they make. It's also important to understand, I think, that there's other factors at play here. The device makers, the people who make instruments, have oftentimes have a subtle role in these guidelines. The people of different specialties may have different perceptions as to what procedures should be done and recommended. So there are multiple factors here at play, I think, beyond the evidence, and I think that's what I hope I'll bring out in this brief talk. Uh, so this is the statement that we began with in that editorial, and what we said is that after reviewing the same evidence at about the same time and from the same sets of clinical trials, medical panels in different parts of the world have issued varying and sometimes even conflicting guidelines. So I think this is the very heart of what I'm going to be talking about. And I think this gets to the whole question of how valid are these guidelines? How reliable are these guidelines? Can we really trust these guidelines? Because when you look at the same evidence at the same time, from the same sets of clinical trials, and you have different groups of doctors in different parts of the world issuing very different guidelines and sometimes very conflicting guidelines, the question becomes, are these really evidence-based guidelines, or are there other factors at play that are threatening the validity of these guidelines? So one of the things that came out when we looked at guidelines around the world is that the American guidelines very often differ from the European guidelines. We see big differences between guidelines issued in the United States and guidelines issued from organizations in Europe. The other thing that we noticed, and it is quite salient, is that specialty societies often issue guidelines that are very different from guidelines issued by independent panels. So a good example of that, for example, is that the American College of Radiologists, the Canadian Association of Radiology, oftentimes have very different guidelines from the Preventive Task Force or the Canadian Task Force. So specialty societies have guidelines that oftentimes differ from other guidelines. And specialty societies in Europe oftentimes differ from guidelines issued by specialty societies in the United States. And these differences in guidelines were evident even after the panels reviewed the same data and the same evidence. So Sunita Sa was a healthcare expert, and so one of the things, as we discussed this and we reviewed some of the literature, what became apparent is that there are two unrecognized sources of bias in clinical practice guidelines. These are biases that are not out in the open, but really, when you look at the patterns of guidelines that are issued and what is recommended, these guidelines, I think, these two biases are very apparent. One is the fee-for-service conflicts of interest. In other words, doctors who sit on guideline panels oftentimes charge for the services and procedures they recommend, and their incomes are oftentimes derived from those services and procedures. So for example, radiologists recommend screening mammography, but in the United States, they derive their income from screening mammography. Doctors may recommend, screening colonoscopy, but they derive their income from screening colonoscopy. And so the question is, does that distort the guidelines? Because if they're deriving their income from the very uh, service or procedure they're recommending, that should be viewed as a conflict of interest. So although the guideline panelists are required to disclose, their speaking fees, their stock ownerships, whether they get money from uh, companies for consultant fees and so forth, they're not required to disclose fee-for-service conflicts of interest, which is very, very interesting. Okay, so the fee-for-service conflicts of interest are never disclosed by the guideline panelists. The other point, the other bias that came out, and Sunita Saw, the co-author of that paper, is really an expert on this issue, is this issue of specialty bias. And what specialty bias refers to is that there's a tendency among doctors to recommend treatments and procedures that they're trained to provide. So even if there is no fee-for-service conflicts of interest, if we omit that issue, there is a subconscious tendency for doctors to recommend treatments and procedures they're trained to provide. So, and Sunita has done a lot of research on this topic and found that this is, in fact, a very, very, very strong bias. So when a patient goes to a doctor who's a surgeon, that doctor is going to be more inclined to recommend surgery because that doctor has been trained to do this particular operation. Radiologists are going to be inclined to recommend screening or procedures, again, that they're trained to provide. Cardiologists may be inclined to recommend invasive procedures that they've been trained to provide. So that's a specialty bias, which is very different from fee-for-service conflicts of interest. But it's these two important sources of bias that I think and felt really threaten the validity of guidelines. And if you really look at this whole big conflicting guidelines issue in more detail, you realize that these sources of bias play a huge role in in threatening the validity of clinical practice guidelines. So I'm going to give you some examples. So let's talk about screening mammography. So the Canadian Association. Now I've got let me go back here. Because I can't see the full screen here because of this, but I can go to my panel here. So the Canadian Association of Radiologists, okay, recommended screening mammography starting at age 40. And the American College of Radiologists recommended the same thing. But we looked at the Canadian because this was an editorial of the Canadian Medical Association Journal. When we looked at the panel, when we looked at the composition of the panel, what we found is that 7 out of the 8 panel members that recommended screening mammography starting at age 40, Canadian Association of Radiologists, 7 of the 8 panel members were radiologists. Now, the Canadian Task Force did not recommend screening mammography starting at age 40. They recommend screening mammography starting at age 50. But 1 out of the 8 panel members, but none of the panel members in the Canadian Task Force were radiologists. So again, Canadian Association of Radiologists, the CAR, recommended starting screening mammography at age 40. But 7 out of the 8 panel members made that recommendation. 7 out of the 8 panel members in that group were radiologists. The Canadian Association of the Canadian Task Force had a very different recommendation. They said, don't start screening mammography at age 40, start at age 50. So interestingly, none of the radiologists or none of the members of the Canadian Task Force were radiologists. Okay, they were all epidemiologists, they were all healthcare experts, but none of them had a background in radiology. Now, it's interesting also, the European Society of Medical Oncology does not recommend screening mammography at age 40, recommends starting screening mammography at age 50. And only 1 out of the 8 panel members of the European Society of Medical Radiologists were radiologists. So again, you see here very different composition of specialists. Okay, there's a huge number of radiologists, 7 out of 8, in the Canadian Association of Radiologists that made the recommendation to start screening mammography at age 40. But no radiologists in the Canadian Task Force, and only 1 out of 8 members in the European Society of Medical Oncology were radiologists. And those 2 organizations did not recommend screening mammography at age 40. They recommended starting at age 50. So the big question is, why is there this conflicting guideline? And could these guidelines be due to the composition of the panelists, of the panels? Now let's go to the next example, prostate cancer screening. Now, the United States NCCN has been a very vocal and very strong proponent of prostate cancer screening. So we looked at the composition of the guideline panel. What we found is that 25 out of 32 panelists were urologists. In the United States, urologists make money from prostate cancer screening. The more prostate cancer screening you do, the more you charge, the more the more things you find, and the more intervention, the more money you make. So the composition of the NCCN that recommended prostate cancer screening was very heavily loaded with radiologists. 25 out of the 32 panel members were urologists. I would say where it's heavily loaded with urologists. 25 out of the 32 panel members were urologists. Now, interestingly, the Canadian Task Force does not recommend prostate cancer screening. And when we looked at the composition of the Canadian Task Force, we found that none of the members were urologists. None of the members of the Canadian Task Force were urologists. They don't recommend prostate cancer screening. And ESMO, the European Society of Medical Oncology, which also does not recommend prostate cancer screening, only one out of the four ESMO members, only one out of the four panelists in the ESMO panel were urologists. So again, huge differences in composition of the panels, okay? And interestingly, the composition seems to coincide with the recommendations. The more urologists you had on the panel, the more likely the panel was to recommend prostate cancer screening. And again, in the screening mammography group, the more radiologists you had in the panel, the more likely the panel was to recommend mammography screening. Okay, so the composition of the panel seemed to coincide with the ultimate recommendations of that panel. Let's talk about colon cancer screening. And this is very interesting. Okay, so colon cancer screening. The American College of Gastroenterologists, okay, had 6 panel members. All of them were gastroenterologists. Now, in the United States, the major source of income for gastroenterologists is screening colonoscopy. Okay, so interestingly, all 6 members of the panel that looked at screening colonoscopy, recommended screening colonoscopy, American College of Gastroenterologists, were gastroenterologists. The United States Preventive Task Force, none of the panel members were gastroenterologists. And in ESMO, they had 1 GI surgeon and 6 medical oncologists in the panel. Now, interestingly enough, the American College of Gastroenterologists strongly recommends screening colonoscopy, whereas USPTF says there's no evidence for screening colonoscopy and recommends fecal occult blood testing, and ESMO says recommends fecal occult blood testing and not screening colonoscopy. And again, the recommendations seem to coincide with membership of the panel. Now, finally, now this is interesting. The prophylactic carotid artery stenting recommendations. Okay, so ACC, the American College of Cardiologists, American Heart Association Task Force, 18 out of the 22 members were cardiologists, and they all do carotid artery stenting. NICE, which is the National Institute of Clinical Excellence, the British task force, there were 5 members on the task force, and they were also all trained in carotid artery stenting. And yet, ACC-AHA recommended carotid artery stenting for asymptomatic individuals. NICE did not. But here we see something very interesting, I think, and that is that in the UK, there's a National Health Service, and most of the members and the NICE members were all members or physicians in the National Health Service. They had no private practice source of income. Whereas in the ACC, AHA, all the doctors had income coming from their private practices. So the divergence in recommendation with regards to prophylactic carotid artery stenting may partly be due to the fact that you had differences in the healthcare systems. ACC, AHA in the fee-for-service healthcare system, and NICE in the national healthcare system. So again, I give these 3 examples, or these 4 examples, to point out that the composition of the panel has a huge bearing on what the recommendations are, and also the setting of the panel. If you're at a National Health Service and you don't derive your income from the procedure, you're less likely to recommend it. If you're in a private healthcare system and you derive your income from the procedure or service you're recommending, you're more likely to recommend it. And the other issue, of course, that I pointed out earlier is there's also a besides the fee-for-service conflict of interest, there's also the specially biased conflict of interest. Specially biased meaning that doctors who do these procedures and who are engaged in these healthcare services are more likely to recommend the procedures and the services that they are trained to provide. Now, here's the table that we published along with the article in the Canadian Medical Association Journal, and we gave those 4 examples: breast cancer screening, prostate cancer screening, prophylactic carotid artery stenting, and colorectal cancer screening. And at the very top, we see the Canadian, U.S. specialty recommendations, and the Canadian U.S. medical specialty organizations had very heavy specialty bias and fee-for-service conflicts of interest. Recommendations from the task force had reduced specialty bias and reduced fee-for-service conflicts of interest, and the European Medical Organization had to reduce specialty bias and little or no fee-for-service conflicts of interest. And so when you look at it from that perspective, you get a better idea as to why there might be these very divergent recommendations from different organizations in different parts of the world. So what's wrong with all this? I mean, what's wrong with organizations issuing these different guidelines? Well, what ends up happening is, I think the real repercussion of these diverging guidelines is there's a tendency as a result of these guidelines, when doctors recommend procedures they train to provide, when there's fee-for-service conflicts of interest, there's a tendency for overdiagnosis. Okay, so overdiagnosis means you find disease that has no clinical relevance and would not pose a threat to life. And a good example of that is breast cancer screening, prostate cancer screening, colon cancer screening, all do the same thing. So in the United States, it has been suggested, in America, in the United States, we start screening mammography at age 40. And it's been estimated that 30% of all breast cancers that are diagnosed in the United States are overdiagnosed. And these are all essentially found on screening mammography. By overdiagnosed, I mean we find disease that would never have posed a threat to life, and in the absence of screening would never have been detected. A good example is DCIS. There's also invasive cancers, learned from a lot of these epidemiological studies. There are a lot of invasive cancers that in the absence of screening would never have been diagnosed. So as a result of this massive overdiagnosis, which is a consequence of these guidelines, we have overtreatment. So we treat disease that poses no threat to life. And as a result of the overtreatment, we can increase morbidity and mortality from treatment. So people could potentially have adverse outcomes because we're overdiagnosing and overtreatment. Also, it's interesting to point out that in the United States, it's been estimated that 25% of all healthcare costs are attributable to waste. And much of that is overdiagnosis and overtreatment, which comes about from these overreaching guidelines that are put together by specialty organizations and others with fee-for-service conflicts of interest and specialty bias. So how do we deal with this problem? Well, I think the first step is disclosure. Okay, so guideline panelists need to also include specialty bias and fee-for-service conflicts of interest in their list of disclosures. They tell us, they have stock ownership. They tell us if they're consultants. They tell us, if they get research grants from these private industries, but they also need to tell us what their specialties are. They need to say, I'm a radiologist, I make money, doing mammograms. I'm a urologist, I make money from prostate cancer screening. And they also need to diagnose their specialties. Even if they're in the National Health Service, they need to tell us what their specialties are, because that may suggest there's a specialty bias at play. And the other thing that we suggested in our editorial is that guideline panelists with specialty bias and fee-for-service conflicts of interest should not serve as voting members of the guideline panels. What they perhaps should serve as is as external advisors. And also, when specialty societies issue guidelines, perhaps they shouldn't call it guidelines. They should call it position statements, which has a very different connotation from guidelines. So when the American College of Radiologists, when the Canadian Association of Radiologists recommend screening mammography, it should not be viewed as a guideline, but as their position statement. And it shouldn't really have a bearing on how we practice medicine. We should just accept it as their position on the issue. And you can take it for what it's worth, but it shouldn't be viewed as a guideline, okay? Now, the third issue that came up is that medical specialty societies should acknowledge that they primarily serve the best interests of their membership. The American College of Radiologists, the American Urological Association, are there to serve the interests of their members, and their members are there or use these organizations as a means to improve their financial well-being. And these organizations don't always serve the best interests of the public. And they probably shouldn't be in the interest. They should probably not be in the business of issuing guidelines. They should be in the business of issuing position statements. And finally, and this is, I think, the real source of the thing, guideline panels should not include primarily specialists, and certainly not specialists with fee-for-service conflicts of interest, but they should primarily include individuals with expertise in epidemiology, biostatistics, and clinical trial methodology. You don't need to be a radiologist to know whether or not screening mammography works. You do need to understand the trials. You need to understand biostatistics. You need to understand epidemiology. That's what's going to decide how well qualified you are to make those kinds of recommendations. It's not your specialty, but it's rather your background in clinical trial methodology, biostatistics, and epidemiology. So panelists should be very low on specialists in their task force or in their panels, and should be very heavy on people with this sort of background, epidemiology, biostatistics, statistics, and clinical trial methodology. So finally, to conclude, worldwide, there are huge variations in clinical practice guidelines. Okay? And these variations may at least partly be attributable to the presence or absence of fee-for-service conflicts of interest or specialty bias. These guidelines and the conflicts of interest from these biases lead to overdiagnosis, overtreatment, and dramatic escalation in healthcare costs. We need to put greater efforts to reduce these biases. We need to have disclosures of these biases. We need to pay very close attention to the composition of the guideline panels. We don't need specialists in guideline panels. We need people with backgrounds in clinical trial methodology. And so the question that Kamal had asked me is, which ones to choose and why? Which guidelines should we choose and why? Well, I would recommend paying close attention to the composition of the guideline panels. And guideline panels that are devoid of specialists, that are devoid of specialty bias and fee-for-service conflicts of interest are the guidelines you should probably pay more attention to. Guidelines that are issued with a very, very heavy concern for specialty bias and fee-for-service conflicts of interest, you can probably ignore. So that's my quick talk, and I'll take questions.